Good afternoon, everyone. Mark Sundrop here, together with Wendy Spearman. Again, it's our privilege and honor to welcome you to this week's UCT Department of Medicine COVID webinar. Again, we have a fantastic lineup of speakers and panelists. Again, just to note and thank the University of New Mexico, Project ECHO, for extending their license for allowing us to use their platform for these webinars. And as usual, we shall open up the chat line to the host only for questions in the latter half of the webinar. But to hand over quickly to your chair for the afternoon, Professor Graham Mankeys. Graham.
Great, thanks very much, Mark, and welcome everybody to this week's webinar. This week we've got a slightly different format. We've got 3 shortish talks from colleagues all based at the University of Cape Town, and we'll cover the spectrum of COVID-19 and the response to COVID-19 from the epidemiology through to the laboratory and then clinical issues. And we'll have the 3 talks first, and that will be followed by a panel discussion where we'll be joined by 2 colleagues from Stellenbosch that I will introduce later. So to start off with, we'll have our usual update on the surveillance of COVID-19 in the Western Cape. Marianne Davies is a public health specialist based at the Western Cape Department of Health and in the UCT School of Public Health. So over to you, Marianne.
Thanks very much, Graham. I thought I would start instead of my usual introductory slide and instead of leaving it to the acknowledgements by showing you the people behind the data from the data center and our data wranglers who are working on an automated EPI report, which we hope to have available soon. And some of their work in particular I'll be including in the talk today. We can go to the next slide. So this is just looking at where we are, and as of today we are sitting on just over 80,000 confirmed test positive cases in the province. Many people draw graphs that are better than ours, so I've stolen one of theirs on the left hand side to show that we are no longer leading the race in terms of cases. Gauteng overtook us as we knew they would last week. But of course we know that quite profound flattening that we see in the Western Cape line is very much due to the reduction in testing and limited testing strategy in the metro. And on the right hand side, the main reason to show that is just to show the continued sort of flattening in terms of mortality in deaths in the Western Cape, but really to show the comparison with the other provinces where we're seeing particularly striking increases for Gauteng in green and the rest of the country in the pale blue, and starting to see increases in KwaZulu-Natal as well. Eastern Cape may be a bit of a flattening similar to ours. So we can go to the next slide. We spent a large part of the last 3 months trying to explain why we were the epicenter of the outbreak. And I just want to refer you to this very nice work from our virology colleagues at Stellenbosch. If you haven't seen it yet, the website is available there, which has done whole genome sequencing of a number of the SARS-CoV-2 specimens from the Tygerberg lab and shown that we have 3 particular clades in the Western Cape. I would be the last person to try to do a molecular epi presentation, but you can see we have 19A in the darker blue, 20A in the light green, and 20B in the yellow. And based on their analysis, they think that there were at least 9 separate introductions of SARS-CoV-2 just on what they tested. But given that that only 10% have been tested, they think substantially more introductions. And based on their dating, that most of these occurred in the last week of February and the first 2 weeks of March, when we were finding the first cases in the country. You can go to the next slide. We always report on tests, and you can see that the number of tests, if anything, have decreased even further in the last few weeks. Positivity seems to remain pretty constant at around 40% for the last few weeks. And I thought I'd just share some of the work from the data wranglers, which is that they've done a population distribution of the whole province on the left-hand side. And then on the right-hand side, the blue and pink bars show the proportions of the population that have tested, and then in orange, the proportion, or the numbers that have tested and the numbers that are positive. And you can see the very striking bulge that we've seen really all along since the start of COVID in the province, which is in our younger working population, still seeing that predominantly in the testing, but I think increasingly also towards the older adults, the 40 through to about 60-year-olds, relative to the rest of the population, given our preference for testing of those groups because of their higher risk. We can go to the next slide. This is also what I show every week, which is across the province, deaths in black, hospital admissions in blue, and ICU admissions in red. And what we really are seeing, and I think this is now pretty much in a lot of the public domain, is something of a flattening in terms of the deaths, which seems to kind of be sitting at just below 40 to 50 a day, and we seem to have stayed there for rather a long time. When I last presented is where the red arrow is, and you can see that at that stage we definitely were seeing an increase in hospital admissions, and we have now seen quite a marked drop just in the last 2 weeks. And if you look at the table on the left-hand side, this is just for the different sub-districts in the metro, looking at the percentage of admissions in the last 7 days compared to the previous 7 days. And you can see that really across all sub-districts, we have fewer admissions. So it shouldn't really say increase there, it's just percentage compared to the previous week. So we have fewer admissions in the last 7 days compared to the previous 7 days, the exception being Western, where it's about the same. In the rural districts, I haven't included that because the numbers just get so small that you can get these quite striking percentage differences. But essentially across the province, it's pretty similar. Some increases in some areas, more in rural than the metro, but we do see this decrease. And then the pattern in ICU just mirrors what we've seen in the hospital admissions. We can go to the next slide. So we haven't talked much, I've talked a lot on these webinars about risk factors for death. We haven't talked much about who is preferentially getting admitted. And so I just thought I'd share this, which is also work from our EPI group, which is looking pretty much in real time at the odds of being admitted. And I think there are no surprises there. Current tuberculosis and diabetes being the number one risk factors, I guess, for admission. What's interesting is that COPD is quite a marked increased odds of admission in people with COPD, but we actually don't see that as a big risk factor for death in our population. And then on the right-hand side, again, with the population pyramids, on the top is looking amongst all cases by age and sex at where the admissions are happening, and at the bottom, amongst all hospitalized patients where the ICU admissions are happening. And I think we can see what we expect in terms of age in both of those graphs, particularly in the bottom one, that ICU not being used in our oldest patients. And I just thought it was interesting. I haven't mentioned children much on these talks, but to note that we do see the one place in children where we are seeing admissions and ICU admissions is in our under fives. And a lot of people have asked about deaths in children. We've had 12 deaths in children to date in the province, 4 in the under fours and 7 in the 15 to 19-year-olds. And many of those are in children with severe comorbidities and in fact, in some cases where the COVID may even have been incidental. We can go to the next slide. So Andrew showed this last week, and I'm really just updating how are we tracking compared to the epidemiological models that we had used for our provisioning or for the scenarios that we may have anticipated. And in keeping with that flattening of deaths, we're here looking at all deaths in the province with some adjustments for those that may not yet be reported, those that may be missed, and also in a proportion of patients under investigation where we may not have made the COVID diagnosis. And I think it's fairly clear that we do seem for quite a few weeks now to have a pretty flat trajectory and well below what the models had predicted. And I'll talk to that a little bit later, but if we just move to the next slide. This is just to look at the MRC data, and are we missing huge numbers of deaths? Is that flat trajectory because we're making a mistake? If we look at the MRC data and we look at the length of the gray bars, those have also been very similar for 3 weeks. And in fact, I've just received the data for this week, but too late to include in the presentation. And if anything, there is a slight further reduction, partly because if you look at the background line in orange, it actually goes up this week normally. So when we look at the difference compared to background, we have seen a reduction, and we don't seem to see any particular increase in the extent of our under recording of deaths compared to what's in the Department of Home Affairs or the MRC data. So we can go to the next slide. So does this mean we're over the worst? Are we out of exponential growth? I'm sure many of you have seen this particular way of looking at the data on Our World in Data. And essentially what it does is to plot the log of daily deaths versus the log of total deaths. And if you're in exponential growth, you should be following a straight line. And then as you get out of that, you suddenly plummet down very nicely, which we can see on the left-hand side, just for comparison. I've shown Spain and Belgium have done. We can see Brazil and India still going upwards, and we can see South Africa also seems to still go upwards. If we look at the Western Cape, maybe there's the start of a plummet downwards, which would be very nice. I will caution, if you look at other countries, they have looked a bit like that, particularly the US, and then bumped upwards again. But certainly there's beginning to see something of going downwards, and then doing the same thing on the right-hand side for the province broken down into rural, Khayelitsha and Klipfontein, where we saw the most cases, the rest of the metro and Eastern and Tygerberg. If you want to squint very hard, I think you can say that rural certainly going up, Tygerberg and Eastern may be still going up, but Khayelitsha and Klipfontein again, if you want to believe that downward curve, it does seem to be heading a little bit on the downward side, and we'll obviously watch that closely. We can go to the next slide. If we are out of exponential growth, why have we not seen what's on the models? And I think my guess is as good as yours, and there are probably plenty of people on this webinar who could answer that question better than I could. What the modelers are going to be doing, and hopefully we will have by the end of this week, is in a sense to model what these curves would have looked like if behavior change or NPIs had been more effective than we have assumed, to model if we have more immunity, some cross-immunity around particularly the papers that have come out around T-cell immunity, or to model what the impact would be of behavioral heterogeneity and more transmission through super spreading events, and see whether any of those will mimic the patterns that we see. Of course, that's not based on the science. That's really just looking at what would the data be compatible with. And then I think the last slide. So Marc Mendelson's going to talk about antibiotic use, and I thought just to lead into that, would present what data we have, a very warts and all look at antibiotic use in the admitted patients, and highlighting the caveats on the right-hand side, which is that this excludes ward stock. It's irrespective of duration, and in the table I've limited to drugs that were prescribed more than 10 times. Essentially 15% of admitted patients have had any antibiotics admitted, and I think the pattern of use is in keeping with the differential diagnosis of a community-acquired pneumonia, and 5% have been prescribed oseltamivir. Thanks.
Great, thanks very much, Marianne. That was great. And I'm sure there'll be a lot of questions when we come to the discussion. So we're going to move on to the next talk, which, as you're aware, there's been a lot of interest recently, perhaps some controversy around the issue of antibody tests for SARS-CoV-2 infection, what their role might be clinically or in monitoring the epidemic, and then discussion about what the performance of the various tests that are becoming available and the variability in performance. And I've asked Di if she would just give us a summary today of serological tests for SARS-CoV-2 that will then obviously lead into our panel discussion, which we can sort of interrogate these issues in greater detail. So thanks very much, Di, and over to you.
Thanks a lot. Hi everyone. So to start off with, the gold standard diagnostic test for diagnosing or confirming SARS-CoV-2 infection remains obviously detection of viral RNA in a respiratory sample. Problem is that the viral RNA in the respiratory tract is only present for a short period of time, and so we need other diagnostics to identify the infection status beyond that, or on either side of that window of opportunity. So we need alternative tests that can give us information about exposure, potentially immunity or susceptibility of a patient. And serology seems like the next most appropriate modality to go for. Serology has been used for a long time as a marker of infection in many virology in virology infections, and so it shouldn't really be surprising that within a few weeks of this new infection being identified, researchers started to work on developing serology tests to diagnose the infection. And what happened was that these tests were given emergency license to be used, and many of them were found to be wanting. In other words, they were providing misleading results, and as a result of this, this generated a lot of sort of disappointment or suspicion in the clinical community. We now have got better tests available, but now we need to really evaluate their usefulness in the clinical context. And that is, that is what we need to do at this stage now. Let me just see. So if one just looks at the serological response during acute infection, antibodies become detectable usually in the second week of the illness, in keeping with the fact that the initial site of the infection is in the upper respiratory tract. Secretory IgA antibodies are usually the first to become detectable, and then IgM and IgG antibodies follow. And with the detection appearance of these antibodies in the blood, this is usually associated with a decline in the RNA levels in the respiratory tract. And so the antibodies, particularly antibodies to the spike protein of the virus, are thought to play a role in the clearance of infection and be important from this point of view. And then the other phenomenon that is quite remarkable is that the level of antibody seems to correlate very much with disease severity, with people who've got more severe disease having much higher levels of both neutralizing and other antibody in the blood, whereas those with asymptomatic or relatively mildly symptomatic have much lower levels of antibody, which is an interesting phenomenon. So before we can really have an idea of the sort of key to determining the usefulness of measuring antibodies in this condition, one's really got to have a better understanding of how durable antibody responses are, and also whether their presence in a patient does confer or provide any kind of evidence of immunity to reinfection. And we don't really have longitudinal studies to base our very, very good ones as yet. And this study, which is actually still a preprint, is one of the studies where there's been the longest follow-up of patients so far. So they followed these patients up for 94 days post-infection. And what these graphs show is the level of these were anti-spike antibodies in patients over that period of time. So longitudinally, they're getting samples from these patients, and they've also correlated this with their severity score. In other words, how severe their infection was to start off with. And what one can see in the graphs is that over this time period, IgM and IgA antibodies decline, which is not unexpected, and that IgG levels on the whole plateau and start to decline. But what was particularly remarkable in this paper was that when they looked at neutralizing antibodies, the antibodies that are supposed to provide protective immunity, there was quite alarming evidence of decline in neutralizing antibodies, to the extent that quite a few of these patients, the antibodies became undetectable after a few weeks to months. And so this sort of information, as well as other data based on immunity to other human coronaviruses, there have been a number of studies that have looked at reinfections with other human coronaviruses and shown that within a 12-month period, a person can be reinfected with the same coronavirus, that there's also an initial spike in antibodies, but that these levels wane and people become susceptible to infection again. So it does suggest that reinfection is likely despite evidence of an antibody response. So if you have a look at the viral epitopes that, or antigens that are are being used for serological tests, individuals make antibodies to the full range of structural viral and non-structural proteins. But there's certain viral proteins which are present in large amounts in infected cells and which are also highly immunogenic, and these have been selected for use as effective immunogens. And in particular, the spike protein, which is obviously important because it is the surface protein of the virus and is involved in attachment to the receptor, the ACE2 receptor. So antibodies to the spike, and in particular the receptor binding domain, are of importance, and assays have been developed making use of these epitopes. In addition, the nuclear capsid protein, which is very abundant, and it packages the RNA genome. and is also highly immunogenic and is the other source, the other common antigen which is used in these commercial assays. So if we look at the different techniques that can be used to detect antibody, so neutralization assays are the gold standard method of detecting antibodies that have a protective effect, that are sort of infection blocking and antibodies. The problem with them is that they are very labor intensive. It requires you to grow virus up in cell culture and mix it with antibodies to see if you can actually prevent whether those antibodies in various dilutions can hold back infection in cell culture. And this also, because this is a BSL-3 organism, it requires BSL-3 facilities if you're going to do proper neutralization assays. What one can do is one can create pseudotype variants. So these are basically fake variants that just express the spike protein of SARS-CoV-2, and these can be used safely in BSL-2 conditions, and they also will give you good evidence of the degree of anti-spike antibody protection. So, but if one is not looking for neutralizing antibodies, you just want to have evidence of exposure, there are far more scalable options that one can do. And there are now ELISAs or assays that are based on the ELISA principle and also chemiluminescent linked immunosorbent assays. And this sort of assay can be run on these large laboratory analyzers that are found in chemistry labs and can really produce high throughput testing. And the other potential usefulness of them is that they can identify different classes of antibodies. So you can look at IgM and IgG separately, for example, or total antibodies. And also the different commercial assays that are available, once again, they're either anti-spike or they tie all nuclear protein antigens. And then the lateral flow immunoassays, which are designed as point-of-care assays, these are the ones that have very bad press because of the fact that the early assays were very lacking in sensitivity and had a lot of non-specificity, and have caused some trouble. Okay, so what would be the appropriate use for COVID serology? There are potential uses. I mean, one could use it, for example, for population screening to determine the prevalence of infection in the population for epidemiological purposes. And here, in this kind of context, you would need to have an ELISA or an antibody test with a high specificity to ensure that you've got an acceptable positive predictive value. The reason being that it does seem that the seroprevalence remains low even in regions where the peak infection has come and gone. So it's single digits, even in places like Spain and elsewhere. And so it does indicate that there's some other factor other than herd immunity that is responsible for protecting people from infection. But that being the case, one is going to you're going to need an assay with high specificity if you want to have reliable epidemiological data. Then these assays are also potentially useful at an individual level. The individuals, for example, who may have had COVID-like symptoms but did not get tested during the acute infection, and where it is helpful to know whether in fact the person was really exposed or not. And also a situation where somebody severely ill looks like they've got COVID, but they are PCR negative. And in those instances, also an antibody test could potentially be reliable, although one has to bear in mind that these antibody tests are not that sensitive in the first week or so of infection. So in this kind of context, specificity is also less of a problem because your pretest probability of being really infected is high, or at least higher than, and it also, in this context, it's also possible that anti-spike antibodies might be more of greater interest or have greater prognostic value than just other responses to other antigens. There was an editorial in the BMJ recently that has showed that sort of drawing attention to the fact that the validation studies of assays that have been done so far have been far from perfect. So it's another problem that we have trying to decide whether serology assays are useful or not. And there were these two recent meta-analyses, one in the Hoffman database, and basically what they found based on the studies that they assessed was that there was selection bias, that there wasn't any long-term data on follow-up of patients. The design and execution and reporting of studies needed to be improved, and they were rather unimpressed and urged caution in interpreting and using serology for clinical decision making. Where does one go from here? I mean, we are in the diagnostic lab. We sort of have we're unsure about the potential importance or worthwhileness of actually setting up an assay ourselves. Would it be clinically useful, or do we not have the information enough yet? But we were asked by the NHLS to validate one of the assays that is run on the commercial analyzer that we have in our laboratory, and that is this Roche Alexis assay. The antigen in this assay is the nuclear protein antigen, so it's not going to give us any kind of binding virus binding antibody, but nonetheless it will give evidence of exposure. And it was assessed by the Public Health England laboratory and found to have reasonably good sensitivity and specificity. And on the basis of this, it was one of the tests that was selected for a validation. And I just thought I'd just show you, we're still busy with that validation, but just to give you some data on what we've found so far. So far what we've done is we've tested historical negative samples. These are frozen samples since from July last year, and where we tested 144, they were all, we were 100% specificity. We've also tested very willing healthcare workers with post-infection who offered their blood in the interests of science, and of those, all 33 were gratified to hear that they had antibodies. And then we've also tested hospitalized patients that were PCR positive. So now in these cases, we don't actually know when the onset of their disease was. All we know is the date of hospital admission. And what we have found so far is that there's a predictable increase in the sensitivity as they progress, as the weeks progress. So we're still busy with it, but I think the assay so far does fulfill the claims of the manufacturer. So I think it probably has some utility. And we're also going to be doing a seroprevalence study on contemporary samples from people attending antenatal clinic, the antenatal clinic, so that we can get sort of contemporary seroprevalence data for the Western Cape. And then we will hope to do this again in a month's time or a month later, just to see if we can track what's going on with the epidemic. Okay. And so just to end, once again, say again that nucleic acid-based methodologies remain the cornerstone for in vitro diagnostic testing. But we do need good serology assays, and the assays do need to have proper validations to determine how useful they really are. We still need clarity on to what extent seropositivity actually equates to immunity, or what it really means long term. But it's probably true that we're not really ready to make clinical decisions based on results as yet.
Thanks very much, Di. So that was a really excellent overview of sort of the key issues with respect to serology testing, and very clear. And great to see that local data that provides some reassurance that that test has good performance. And I just wanted to add that Di is a clinical virologist and head of the diagnostic virology lab at Hardie, and pay tribute to Di and all of her colleagues working in that lab for the critical role that they've played in the scale-up of PCR testing to help us deal with the surge of COVID-19 in the Western Cape, both at Hardie and at the hospitals that refer samples to Hardie. So to say thanks for all the hard work that you and your colleagues have put in the laboratory in terms of the support for the clinical services. So we're going to move on to our next talk, and it's the third talk, and after that we'll move on to the panel discussion. Marc Mendelson is Head of Infectious Diseases at Hardie and UCT, and Marc is also the Chair of the National Ministerial Advisory Committee on Clinical Issues. And Marc's going to address a very important issue that is often raised by clinicians working in the COVID service, and that is, what is the role of antibiotics in patients presenting with suspected or confirmed COVID-19? So over to you, Marc. Thanks very much.
So thanks very much, Graham, for the invitation to speak. I'm just going to start the presentation, I hope. Okay. So, like a number of other major public health issues, including many of the non-communicable diseases, antimicrobial resistance as a major public health crisis has collided with COVID-19. And I think it's important, as we're now really transfixed on death rates and impacts of this epidemic, indeed pandemic, to realize that there are other pandemics still ongoing, slower perhaps than we are dealing with COVID-19. But just to remind ourselves that the modeling suggests by the year 2050 from the O'Neill report that there will be an excess of 10 million deaths from antimicrobial resistant drug, and predominantly those being antibiotic resistant bacterial infections, and that the predominant hammer blow falls on Africa and Asia in low income countries. Apologies. Sorry, I'm just trying to. So in South Africa, we have a major epidemic of multi-drug resistant bacterial infections at high level. including particularly the gram-negative bacteremias in terms of the Enterobacteriaceae, Klebsiella pneumoniae, and also the non-fermenters, Pseudomonas and Acinetobacter, with high levels of resistance to carbapenems, and with Staph aureus, 1 in 3 still, around, excuse me, around 28% of bloodstream infections of Staph aureus are methicillin resistant. So, even prior to COVID and currently, we are in a position that antibiotic resistance is a major issue and a major problem, cause of death and mortality, morbidity, increasing length of stays in hospitals, places a huge burden on our health service, and is predominantly driven by antibiotic use, which brings COVID-19 into the equation because of the potential for high empiric antibiotic use. So the 5 questions I'm going to very briefly address are listed here. What is the potential impact of COVID on AMR? And what's the scale of bacterial infections, both generally and then in the ICUs? Are there biomarkers that can help us in empiric prescribing? And what should stewardship look like in a time of COVID? So the first question around what is the impact potentially of COVID on AMR is quite complex and has potential enablers and challenges. So there are factors which could reduce antimicrobial resistance, such as the increase in hand hygiene and infection prevention practices that we're seeing in our hospitals, which might reduce spread. Because of social distancing and lockdowns, there may be a reduction in antibiotic-seeking behavior, and therefore you would reduce antibiotic use, which would then theoretically reduce antibiotic resistance drive. And then also the reduction in services such as acute, routine surgery may reduce transmission and carriage of drug-resistant organisms in the hospitals. But similarly, there are a lot of areas which could impact and increase on antimicrobial resistance. And so because of the pressures on our service, we may be less able to isolate multi-drug resistant organism carrying patients, which could increase spread. Because PPE is directed to COVID services, you may again increase nosocomial spread of drug resistant organisms. And the big drive potentially of empiric antibiotic use will select out drug resistance. And then there are a number of other issues, including the fact that we have all been redirected from our normal day jobs. And prior to COVID, antibiotic stewardship was a major part of the role that infectious diseases certainly played in Hardie and elsewhere. And so redirection into the COVID service has impacted potentially on antibiotic stewardship programs. So what is the evidence for bacterial co-infection in COVID-19? And the predominant studies, or the majority of studies, come from China, but also some from a couple from the United States and Singapore. And overall, the pooled prevalence of 29 observational studies on a single randomized controlled trial in this systematic review meta-analysis showed the overall pooled prevalence of defined bacterial pooled co-infection was 7%. So it's really low. And you would expect that in critical care units, ICUs with more severe patients, on a subgroup analysis, that bacterial co-infection would be increased, and that's likely to be hospital-acquired infections. And the other note was that the profile of bacterial co-infections when they were detected was very different from influenza, which does have a high pressure from strep pneumonia and Staph aureus in particular. But predominantly, these bacterial co-infections that have been picked up have been Mycoplasma pneumoniae by IgM, which has got very poor specificity. And in fact, in MERS studies, when Mycoplasma pneumonia was picked up as a co-infection with IgM, the our PCRs at the time were all negative at acute diagnosis. So it really raises questions about whether these are significant results in the COVID patients. Now, what about in ICU? What is some of the upshot of the issues of COVID? One upshot is an increase in laboratory ordering, or clinical ordering of tests in the time of COVID. And this study from New York on a very large number of patients showed a massive increase within the 2 halves of the month of March, an increased ordering volume by 1/3. And the bacteremia rates were very low, with very high rates of contaminants from commensals. The true commonest bacteremias that they saw, and as I said, the rates were very low, were mainly gram-negative bacteremias with a small amount of Staph aureus. But we've also seen high levels of contaminants at Hardie on discussion with Stefan Opperman. And I think one of the problems is that it also puts a great pressure on the laboratories with increased demand with very little gain. So in in bacterial co-infections in the ICU have been, in terms of nosocomial infections, have been described in a couple of studies, one from China, shown here, where secondary infection was diagnosed when there were clinical symptoms or bacteremia with positive cultures. And they looked at those that survived ICU and those that died in ICU, and found that the median time to secondary infection was late. And this really does suggest that the major issue here is hospital-acquired infection, as opposed to patients coming in with a community-acquired infection. And another study from France showed in patients undergoing blind bronchoalveolar lavage that there were multi-drug resistant infections in late onset ventilator-associated pneumonia. And these patients had a very high empiric antibiotic use prior to the admission to the ICU, which is likely to have selected out these more resistant bacteria. So again, the use of empiric antibiotics in hospital has the potential collateral damage of selecting out more multi-drug resistant infections later in the course of their hospital admission. So despite very low numbers of identified numbers of bacterial co-infection, the number of patients receiving antibiotics, of COVID patients, confirmed COVID patients receiving antibiotics, is huge. And it basically is sort of between 58% and 100% of patients in these studies across China and the United States. And in data from the ISARIC consortium, so the International Severe Acute Respiratory and Emerging Infections Consortium, which is heavily biased towards UK hospitals, but in 36,749 patients, 83% were receiving antibiotics in hospital. So there's a huge burden of antibiotic pressure being exerted during this time of COVID. Guidelines generally have weak evidence associated with them. The Surviving Sepsis guideline for those in ICU suggests empiric antimicrobials and antibacterials over none, but they identify that the evidence is weak and of low quality. And most of the evidence is based on experience with influenza, which, as I've noted, seems to be different from COVID. It's also interesting to note that in a community-acquired pneumonia China network study, huge numbers identified the fact that patients who just had viral community-acquired pneumonia with no evidence of bacterial pneumonia could also present with sepsis in around 40% of admissions, and therefore the development of sepsis in viral infections, and some of these were coronavirus infections, does not automatically mean that the patient has a bacterial infection, although granted, it is difficult to withhold antibiotics if you have somebody in sepsis. Cognizant of time, so I'm going to push through these, but the bottom line is that procalcitonin, despite being a predictor of severe COVID-19, of about a 5-fold higher risk of severe COVID in patients that do have raised PCT. The evidence for its use in empiric prescribing of antibiotics when patients come in is actually poor. And very, very few studies have looked at this at all. So what could a raised PCT mean in somebody presenting with likely COVID-19? It could mean bacterial co-infection, of course, but it could also, in the severe cases, be a marker of the severity of ARDS. It's been shown to predict worse ARDS. And it could also be that the induction of immune dysregulation from SARS itself and the lung damage could cause cytokine release, which might increase PCT. So most guidelines do not advocate the use of routine procalcitonin, such as the NICE guidelines. And in the NICE guidelines, if there is confidence that clinical features are typical for COVID-19, it's reasonable to not start empiric antibiotics. And in fact, that is our position at Hardie Skier, that if we are faced with a patient who is coming in with a clinical diagnosis of COVID-19, although it's practitioner dependent in general, our position is not to start antibiotics. So what is happening to antimicrobial consumption at Hardie Skier Hospital? These are quarters. The first quarter of 2021 corresponds to April to June of this year. Fourth quarter is January to March. So this is really the fourth quarter. The two right-hand bars are what we're looking at for this part of this year. And if you just look at the red line rather than the blue bars, which are around cost, the red line is the defined daily doses. And you can see that in the time of COVID, there has been an increase in ceftriaxone use. The amount of co-amoxiclav is a bit more difficult to tease out because we're using different, the 600 milligrams, which of course has shot up, but you see a reduction in the 1.2 gram. So there has been a slight increase, as I said, in beta-lactam use, and we've seen a marked increase in oseltamivir use, despite the fact, as a precautionary principle, despite the fact that there's almost no flu about at the moment. And I don't think there's evidence that oseltamivir should be used at the present time with the epidemiology that we know. We've seen a very marked increase in DDDs of azithromycin and more recently clarithromycin because of a stock out of azithromycin. And again, I don't think there's good enough evidence to suggest the need for azithromycin in general, certainly in the amounts that are being used. In terms of hospital-acquired type antibiotic, piperacillin, tazobactam, amikacin hasn't really shown an increase, nor has ertapenem. We have seen an increase in meropenem over the last couple of years, and that probably reflects an increase in our carbapenem-resistant infections and an increase in the dosing we're using to optimize antibiotic dose. So that will increase the DDDs overall. So lastly, is our reduction in hand hygiene, is our improvements in hand hygiene, which we think having any impact at all from an infection prevention control point of view. In terms of, we know that improving hand hygiene reduces the incidence of Staph aureus bacteremia. So are we seeing that this at all? Is there any signal at Hardie Skier? And the answer is that we are doing the same sort of number of blood cultures, but unfortunately we're not seeing a massive reduction in Staph aureus bacteremia overall, although the numbers of MRSA, and these reflect percentages of total Staph aureus bacteremia, total blood cultures, but obviously it mirrors the numbers. And we are seeing a drop-off of MRSA in our blood cultures over the last couple of months. I don't know how one interprets that because the levels are very low anyway, but it doesn't look like there's a major signal that our hope for improvement in infection control has reduced Staph aureus bacteremia rates. That may be partly because, of course, there's still a lot of intravenous lines being used for intravenous antibiotics and others. So the checklist and what antibiotic stewardship should look like in the COVID era is really the same as it was before. The critical issue is there an indication for antibiotics? And again, I appreciate this will be practitioner dependent and people will have different views on this. But certainly in my experience and in many of my colleagues' experience of seeing a lot of COVID patients now who we are not giving any antibiotics, we do not recognize deterioration due to bacterial pneumonias in those patients. And therefore I would not use antibiotics in a patient I felt was clinically had COVID, unless there was a very high white count in that patient when they were not on steroids, or there was very significant lobar consolidation, which may increasingly suggest a bacterial infection. But in general, we're not using it. It's still important to send appropriate cultures, albeit the increase in blood cultures we've been seeing have generally, internationally, have generally not given the sort of information that we need or want. The antibiotic choice is clearly important. We still look to use the access group antibiotics, the narrowest spectrum possible, and then obviously optimizing dosing interval and route. Unfortunately, these two charts that are shown, 2011 is the top chart, where it was standard practice prior to antibiotic stewardship programs that people would come in and be given 2 weeks of ceftriaxone, irrespective of what they came in with, basically. So it was top left-hand corner of the chart. You could set your watch by it. With the antibiotic stewardship programs, that has improved greatly. But now we're starting to see bad practice seeping back in. And this lower chart from a few days ago showing for a pneumonia, ceftriaxone and azithromycin being used for 10 days, or prescribed for 10 days. And as an antibiotic stewardship maneuver, these were stopped as immediately they came onto our wards. So de-escalation of antibiotics on basis of cultures and on the basis of the route is critical to get those IV lines out so we can impact on bacteremia rates. So in summary, the COVID-19 is likely to negatively impact on AMR. Co-infection rates are low in pooled prevalence in a systematic review and meta-analysis. I don't think there's enough data to recommend an expensive test like PCT for routine decision-making. And we do not recommend the use of empiric antibiotics if in confirmed case of COVID or high clinical suspicion, despite what the chest radiology may be pointing you towards. You cannot tell the difference. But we are not experiencing bacterial co-infections at a level where we would suggest empiric antibiotics for all patients. And the principles of stewardship are still critical and should be upheld. And with that, I will stop and thank Stefan Opperman from microbiology for his data and Varni Naika from pharmacy for hers. Thank you.
Great. Thanks very much, Mark. That was an excellent overview and highlighting a really critical issue and really informative to see that local data. So we're going to move on to our panel discussion, and just to introduce the two panel members are Wolfgang Preiser. Wolfgang is head of virology at Stellenbosch University and Tygerberg Hospital, and Arifa Parker, who's an infectious diseases physician also at Stellenbosch and Tygerberg. So I'm going to invite Wolfgang to make a few comments first, particularly speaking to the issue of the serology tests and what role that he thinks serology might play in the COVID-19 response.
Thank you very much. Yeah, I think most of you will have followed the unfolding saga of some strife being becoming obvious in public media about the role or not role of serological assays, and that is definitely compounded by the fact that the assays that we have so far are anything but perfect, and that there are so many unknowns. Unfortunately, and you know that as human virologists, until SARS-1 came around in 2003, we're blissfully ignorant of the human coronaviruses. In fact, two of those that have been around for decades, if not centuries, were only discovered subsequent to SARS in 2003, so during the 2000s, just because as agents of harmless upper respiratory tract infections, they did not deserve our attention. And of course, there was also no diagnostic need, really. So in other words, we never really devoted much efforts to setting up antibody testing. And I think we are now feeling the consequences of that. There is so much that we don't know and understand so far. And the picture is obviously far more complicated than one would have hoped for. It's not that 100% of people will have detectable antibodies 10 days to 14 days after infection. And I really appreciate Di sharing her results. It is difficult. I think there are biological issues that we haven't fully understood about their meaning, and there are also issues about the assays, and that is perhaps not so surprising in that the whole agent, of course, is new. So it becomes definitely confusing when you look at the avalanche of particularly rapid antibody tests that are being touted left, right, and center as the tool to combat COVID. And to be honest, we've again seen that from Di's data very nicely. A marker that becomes detectable with a great deal of certainty 2 to 3 weeks after the acute event started, then combining that with a rapid test is sort of, in its own right, doesn't really, I don't see the call for and the need for rapid testing really in something which we are looking at retrospectively. So, that is just to again, emphasize how little we know and how much work there remains to be done. But that said, I think the assay that Prof. Hardie and her team evaluated here, and likewise the other two lab-based assays, one made by Abbott and the other one by Euroimmune, for which there's also a number of validation studies from around the world, that none of which is perfect. I think they deserve being introduced, but we need to be very cognizant for what purpose. So one, there are these rare manifestations of COVID, particularly in children. Well, I don't remember the proper name of it currently, but where antibody testing is the diagnostic, seems to be the diagnostic test of choice, seeing that this develops typically after PCR may have become negative already. Another use, which is more a legal and bureaucratic indication, is in healthcare workers, as I learned from our occupational health specialist, Dr. Mankis, who says that in order to claim a compensation, you need to prove that you had been infected. And healthcare workers that are likely to have had COVID but don't have a positive PCR test to show, may be able to claim that by showing a positive antibody test now weeks after that event happened. So I do see, and of course there is a number of research applications, and I think this is really, it's for epidemiological purposes, it's for surveillance as an add-on to PCR testing. I think the two dangers that also led to the relatively slow movement here in South Africa towards introducing these antibody tests. The two risks is that firstly, they may be mistaken as a suitable tool for diagnosing acute COVID, particularly now that in other provinces, luckily we in the Western Cape are past that stage. We are dealing with long turnaround times and delayed diagnoses and limitations to lab capacity. So there, where people may just reach for any straw that is being offered. And the second danger that is out there is that the meaning of a positive test would be misinterpreted as meaning indicating immunity, and would lead to neglect of the usual precautions. And I think this is the two things that we are worried about, and which we need to prevent. In terms of the way forward, SAHPRA has now licensed one point of care assay that came out of, well, not nowhere, but about which I cannot find much evidence in the international literature, even the grey literature from other bodies, which has now been licensed for use here. And I think the three main laboratory-based assays are approaching also licensure here in South Africa and will be used. But this will be used under for certain indications only. So it's not going to be a free for all, and you can interpret it as you please, which again in my mind speaks rather for using laboratory-based assays first, because then you can control to a large degree what the pathologists who need to sign out those results, how they interpret them, and the comments that they add. And I think that's one of the risks of point of care tests, that they are done out there, and we have very little control over how what the story is that the client is told about the result and its meaning. So yeah, I think these are the main. There is a very rare conditions in which there may be a diagnostic role in the primary sense of the word. I think there are these legal implications of being able to prove that one has had the infection at some weeks previously. And then thirdly, and I think this is really the main use going forward for the next few months, is to better understand the epidemiology. And I think this is really where having antibody tests in the context of properly planned and executed surveys and surveillance studies is where they will become important.
Great, thanks Wolfgang, for those really useful comments. So I'm going to move on to Arifa. And Arifa, were there any questions that you wanted to pose to Marc, or issues that you wanted to raise regarding antibiotic use at Tygerberg?
Sure. Good afternoon, and I'll start off by thanking Graham for including me in the panel, and I felt that both talks were quite excellent. Before I ask a question, I'll sort of just give our Tygerberg experience with COVID. So in the beginning, we obviously didn't know what to expect, and we weren't sure if we would be able to differentiate COVID from influenza or community-acquired infections or atypical infections. So the protocol initially was that for severely ill patients, we would give empiric antibiotics. And then, as with time, we became more familiar with the patients. We actually realized that the patients who come in with COVID actually have a very typical presentation. So generally a 5 to 7 day history of symptoms. If they have an osmia or loss of taste, it's very specific for COVID. And the patients have typical comorbidities, almost very similar blood gas pictures. They're not as tachypneic and vasodilated as patients with the community-acquired bacterial infection or even PCP. And then the radiological picture is very, very characteristic. So we're quite comfortable to actually not start antibiotics in patients who do present with COVID. and you know, we feel quite comfortable to do that in the ward patients, and we're actually doing that in ICU. And I actually looked at our antibiotic usage since our first admission. For the first month, we had a big spike in antibiotic use, and as time went on, our antibiotic use has decreased with a rise in admissions, and we haven't seen adverse outcomes in our patients. So I'm very, very comfortable that we definitely should not be using unnecessary antibiotics in our COVID positive patients. And then the other issue is secondary bacterial infections. We are not really seeing that in the wards. And in ICU, we are seeing very similar to the article that Mark, the Lansbury data that he showed, the typical gram-negative ICU infections, which is probably more related to the ICU devices that the patients have in the intubated lines, etc., and possibly not the COVID per se. But I think one lesson from the COVID-19 pandemic is we don't really have treatment for COVID. And I think it's a warning to us that we need to use our antibiotics judiciously, because this is what we could face when antibiotics don't work. So we need to use our antibiotics wisely. I just wanted to ask, Mark, we are seeing slightly elevated white cell counts in the absence of sepsis, which I feel is probably due to COVID. So I'm not sure how useful it is to say that if the white cell count is elevated to start antibiotics, because I find that if it's the typical patient, typical clinical picture, radiological picture, low lymphocyte count, that it might still be COVID, and we don't need to use antibiotics in that setting. I'm not sure what the experience at GSH is like.
Thanks.
I would agree with you. Sorry, is that okay, Graham?
Yeah, go for it. Yeah.
Yeah, no, I mean, Arifa, I agree with you. I mean, we also see patients with slightly elevated white counts. We look at the differential count, the low lymphocyte count, you know, is telling. And I agree. I mean, you can tell now with the experience we've gained, you know, can have a very good feel for what COVID patients look like. So I'm talking really about, you know, patients who are coming in with very high white counts, and particularly if they've got, you know, left shift and you know, potential signs of bacterial infection, then I may err more on the side of an antibiotic. But in general, I mean, I literally stop almost every patient on an antibiotic who's coming in with, definitely with confirmed, but even with high clinical probability. And we are not seeing any damaging effects from that. So I don't think they play a role in empiric treatment. Thanks.
Yeah, I mean, Mark, I would agree. You know, I've seen patients with neutrophilias and everything else is compatible with COVID, and not put those patients on antibiotics. And you know, I think that you know that a proportion of patients, from what I understand, 10-20% can have a neutrophilia. It is a poor prognostic sign, but it doesn't represent bacterial infection necessarily if there's nothing else, no other features.
Yeah.
So I think I will now turn it over to Marc Sandrup, and because I think there are a few questions that have been addressed, or Wendy from the chat room. Do you want to pick up on that?
Yeah, Graham, as you see, we've been trying to answer some of them during the discussion. There are a few outstanding ones. There was one that came through now around issues of whether there's cross-reactivity of the antibody assays with other coronaviruses that a patient may have had in the past. I have given a partial answer from Di, but maybe she'd like to expand upon that at this point because it's an important issue.
So my understanding is that certainly with the more recent generation of tests that are currently being evaluated, that cross-reactivity seems to be minimal. I mean, we do know that at a T cell level, we suspect that there is cross-reactivity, but that's not antibody, obviously. I don't know if Wolfgang has any other calls.
So, Di, I mean, the data that you showed of, you know, the historic samples, none of them were positive, you know, would be quite compelling data to suggest that we're not seeing cross-reactivity.
I agree with that, and in fact, there are other for these more recent assays. The data is similar in terms of specificity, or the claims, I should say, the claims are.
Graham, we had one good question there, which I did answer around whether there's cross-reactivity with HIV at the moment, serological testing. That is something that's been validated. We understand. We have answered that. Maybe for Marc Mendelson, what would be your use of oseltamivir at the moment clinically in the wards?
So, you know, early on, and particularly, you know, right at the beginning, I was advocating very strongly to use oseltamivir. At that stage, in the Western Cape, we had a very small epidemic start, seasonal epidemic of influenza start, just prior to lockdown, which completely flattened it, in fact. And so, you know, oseltamivir, I was using oseltamivir in many patients coming in those early stages. The flattening of that epidemic and the fact that the surveillance at present, albeit attenuated by a number of factors around the COVID epidemic, so it's not quite as robust as we normally see, that is not showing a signal for influenza at present. And so I haven't used oseltamivir in, I think, the last month plus, and I don't think it has a major effect at the moment.
Thank you, Graham. That's probably covered most of the stuff. We've tried to answer most of them online at the same time. Thank you.
Thanks very much. So it just remains to say thank you to all three speakers for really excellent talks that, you know, covered the scope of the response to COVID-19, and as well as the two panel members for the discussion that was very useful following the talks. And to say that next week we'll be back again, Wednesday, same time, and the webinar will focus on palliative care with our speaker, Renee Kraas, who has been leading the palliative care services at Groote and the COVID services. So thanks very much, and join us next week. Over to you.
Yeah, great. Thank you very much, and thank you again to everyone for attending. I just think we need to mention as well that every week you see Graham, Wendy, and myself and the panelists and speakers, and I think going into the 4th month of doing this, we should note that there's back-end support for all of this. So to Cheryl Valentine, who responds to the emails, who is in fact part of Project ECHO, and to Karen Fenton as backup from the Gastroenterology Foundation South Africa, we thank them for all their help and support, and we look forward to seeing you next week. Thank you.
Thanks very much.